Imagine, just for a second, that you are taking a refreshing dip in a really quiet, sunlit, freshwater lake.
Sounds pretty nice, honestly.
Right. I mean, you dive in, you feel nothing but cool water against your skin. It's completely idyllic. But beneath the surface, there's this microscopic, almost alien invader just waiting.
And it's not like a leech or something.
Exactly. It doesn't bite you. It doesn't scratch you. It simply senses that you're there, swims up, and slips seamlessly right through your intact skin.
Just a completely silent entry.
Yeah, just right into your bloodstream,
Yeah.
where incredibly it could live and, quietly multiply for the next decade.
It really is the stuff of nightmares.
It totally is. So today, we are taking this dense stack of medical notes, epidemiological research, and clinical pathology to completely decode one of the most complex, devastating, and just utterly fascinating parasitic diseases on Earth.
Schistosomiasis.
The schistosomiasis. So whether you are like a medical student prepping for your board exams, or maybe a public health professional, or just an insanely curious learner who loves understanding how biology works, this deep dive is going to completely change how you view a simple swim in a lake.
It really will. I mean, the medical literature we're dissecting today, it provides this exhaustive clinical picture of a parasite that has evolved to just perfectly exploit human biology.
Yeah, we are going to arm you with a thorough clinical understanding of this disease. We're breaking down the mechanics of the parasite, the immune response, the exact clinical treatments, all without, getting bogged down in impenetrable jargon.
Right. Because we want to examine everything from its bizarre, like shape-shifting morphology and its multi-stage life cycle to the really severe systemic complications it triggers.
And obviously the very precise pharmacological protocols required to eradicate it. But to really grasp how this parasite attacks the body, I think we have to start by understanding the sheer scale of the threat.
Oh, absolutely. The scale is massive.
Because for a lot of people living in non-endemic areas, this disease is just a profound global health blind spot. You just don't hear about it.
You don't, but when you look at the epidemiological data, the numbers are just staggering.
Right. It's basically right behind malaria and intestinal helminthiasis.
Yeah, which are essentially your standard intestinal worm infections.
Exactly. So right behind those two, schistosomiasis ranks as the third most devastating tropical disease in the entire world.
Globally, we're looking at a major driver of morbidity and mortality that impacts over 200 million people.
200 million. That is just a wild number.
And it spans across 74 different countries. It heavily impacts developing nations across Africa, the Caribbean, Central and South America, East Asia, the Middle East.
It's everywhere.
It really is.
Yeah.
And what makes it so pervasive is that it isn't, some isolated niche condition affecting only a specific vulnerable demographic.
Right. The notes say people of all ages and both sexes are entirely susceptible.
Completely. Wherever the specific environmental conditions allow this parasite to thrive.
Which is what? Slow-moving fresh water?
Exactly. Slow-moving fresh water combined with poor sanitation. Wherever you have that, the risk of infection is virtually universal for the local population.
Okay, so we have this massive global footprint. Let's properly introduce the enemies here, because pediatric and adult schistosomiasis isn't just caused by one single type of bug.
No, it's not. It's principally driven by 6 specific species of parasitic worms.
Right, and they belong to a broader class of organisms called trematodes.
Commonly known as blood flukes.
Blood flukes, specifically of the genus Schistosoma. Let's actually get these specific names on the board so we know exactly who we're dealing with today.
Good idea.
So we have Schistosoma hematobium,
Right.
Schistosoma intercalatum, Schistosoma japonicum,
Mm-hmm.
Schistosoma maliensis, Schistosoma mansoni, and finally Schistosoma mccongi.
That's all 6. And while those 6 distinct species share, many fundamental biological traits, the specific species a patient is infected with really dictates almost everything about the clinical progression of the disease.
Like where it ends up in the body.
Exactly. It dictates where the parasite ultimately settles within the human vascular system, the specific type of organ damage it causes, and, as we'll explore later, the exact dosage of medication required to actually kill it.
Okay, so I was looking at the morphology notes for these guys, the physical structure of these worms, and this is where the evolutionary biology just becomes deeply fascinating to me.
Well, shape-shifting is incredible.
Right. Because generally speaking, trematodes, or flukes, they're known for having a very flat, leaf-like shape. That's like a common characteristic of that entire class.
Yeah, that's standard for a fluke.
But these 6 schistosomes are entirely different. They are elongated, and they have physically adapted to change their shape. They become cylindrical and round.
Yeah, they do this specifically so they can adapt to residing inside the tubular human blood vessels.
Like the veins of the genitourinary or gastrointestinal tracts. It's just a remarkable adaptation. Because if you imagine like a flat leaf-shaped object trying to survive in a rapidly flowing river,
It would be a disaster.
right, it would catch the current, get swept away,
Yeah.
or immediately fold up and cause a catastrophic dam.
Which is exactly why they evolved this way.
Mhm.
The physical forces inside the human vascular system are just immense.
I can imagine.
So to survive in that fast-flowing environment, millions of years of evolutionary pressure selected for that cylindrical shape.
So they're aerodynamic, basically.
Well, hydrodynamic, technically. But yeah, by becoming round, they're perfectly hydrodynamic within our veins. They can navigate the really complex branching architecture of the human circulatory system without triggering immediate fatal blood clots.
Because a blood clot would kill their host before the parasite even had a chance to reproduce.
Exactly. It's a survival mechanism.
But our bodies obviously don't just passively accept a hydrodynamic worm swimming through our veins. The immune system is constantly surveilling the blood.
It is.
And the medical research mentions that immune responses actually intensify with secondary and subsequent exposures to the parasite, which honestly seems like a double-edged sword. Well, on one hand, you want your immune system to fight back. But on the other hand, an intensified immune response is often what causes the severe symptoms of an illness, right?
That touches on a really complex aspect of how humans interact with endemic parasites. Because humans they can actually develop a partial acquired immunity to schistosomes over time.
Okay, partial immunity. How does that work?
It's heavily driven by the presence of specific antibodies that the immune system learns to mass produce, along with a really specialized type of white blood cell called eosinophils.
Eosinophils, I've heard of those.
Yeah, they're essentially the heavy artillery of the immune system. They're specifically designed to attack multicellular parasites that are just too large for standard white blood cells to simply engulf and digest.
Because a normal white blood cell can just sort of swallow a bacteria, but it can't swallow a whole worm.
Exactly. So eosinophils have to kind of attack it from the outside.
But the crucial detail here is what that acquired immunity actually targets. Because reading the notes, it doesn't seem to touch the adult worms that have already established themselves in the veins.
No, it doesn't. And that is the insidious nature of this disease.
Yeah.
The acquired immunity primarily targets the immature incoming worms, the juveniles.
Oh, wow. So if someone living in an endemic area is constantly exposed to infested water, their immune system gradually gets better at intercepting and killing the new juvenile invaders before they can grow up.
Right. But the established adult worms, they possess these sophisticated mechanisms to evade this immunity.
Like camouflage.
Basically,
Yeah.
they often coat themselves in host protein so the immune system doesn't even recognize them as foreign. They just look like normal human tissue.
That is wild, and that dynamic actually perfectly explains a really specific epidemiological observation in the notes.
At HP.
Yeah. The data shows that the highest disease manifestations, like the most severe physical symptoms,
Yeah.
occur in the second decade of life. So teenagers and young adults are hit the absolute hardest. But if they are developing immunity to new worms, why are they suffering the most severe symptoms at that specific age?
It's all tied to the parasite's reproductive cycle. By the time a patient reaches their teenage years, assuming they were, first infected as a young child,
Which is very common in these areas.
very common. By that time, the adult worms have fully established their presence in the veins. They've reached their maximum biological maturity.
Okay.
So the second decade of life is when the sheer volume of egg output from those mature, surviving adult worms hits its absolute peak.
Wait, so it's not the worms themselves causing the massive disease flare-ups?
No, not at all. It's the sudden, overwhelming volume of eggs they're producing. That is what triggers an incredibly violent inflammatory response from the host's immune system.
Man, okay, that sets the stage perfectly.
Yeah.
We have these 6 hydrodynamic culprits hiding in the veins, causing immense damage by the time the patient is a teenager. So let's look closer at their biology. What exactly separates schistosomes from basically every other fluke out there?
There are 2 highly specific biological terms used to describe them.
Right, digenetic and dioecious.
Right.
Breaking those down really reveals just how bizarre their existence is.
It really does. So digenetic is a fundamental concept in parasitology. It literally means the organism lives a double life.
Like a spy?
Kind of. It means it requires two completely different hosts to complete its full life cycle. It
Okay.
just cannot survive and perpetuate its species with only one.
Wow.
So for schistosomes, they undergo sexual reproduction inside the definitive host.
Which is us, humans.
Right. But before they can do that, they absolutely rely on a phase of asexual reproduction in their larval forms, which takes place entirely inside an intermediate host.
And that intermediate host is the water-dwelling snail.
Exactly.
The evolutionary strategy here is basically splitting their bets, right? They use the snail to clone themselves by the thousands, just playing a massive numbers game.
Yeah, asexual division.
And then they use the human host for the actual mating and genetic mixing.
It's an incredibly efficient way to guarantee survival. I mean, the outside environment is hostile, and the chances of a single parasite finding a human host are incredibly low.
So they need an army.
Right. By utilizing asexual reproduction inside the snail, a single incoming parasite can amplify its numbers exponentially. It releases thousands of clones into the water, vastly increasing the statistical odds that at least one of them will successfully penetrate a human.
Okay, so that's digenetic. Then we have the second term, dioecious. And this concept is honestly mind-blowing when you consider how most parasites operate.
It really is unique.
Because unlike other flukes, which are hermaphroditic, meaning, a single organism possesses both fully functional male and female reproductive organs and can just self-fertilize, schistosomes are different.
Very different. They have distinct, separate male and female sexes.
Which is crazy for a fluke.
It is the absolute defining characteristic that taxonomically separates them from all other trematodes. They're sexually distinct. But the fascination, it lies not just in the fact that they have different sexes, but in the actual physical mechanics of how those sexes interact inside the human body.
Yeah, the physical mating arrangement is unlike anything else in human biology. The notes say the two worms are perpetually paired.
Perpetually.
The male worm has this specialized physical groove running along its body. It's called the gynecophoric canal.
Right.
And the female worm, which is longer and much thinner than the male, she physically lies enclosed within this groove.
It's a permanent embrace.
It really is. I mean, you could think of it as like a biological docking station, or like a microscopic sidecar on a motorcycle, or even just a hot dog in a bun.
A hot dog in a bun is surprisingly accurate.
She spends her entire adult life tucked inside the folds of the male's body while they navigate the bloodstream together.
I like to describe it as a life support tether because it is a state of profound biological codependence.
How dependent are we talking?
Well, the female worm's very maturity, her ability to develop fully functioning reproductive organs, depends entirely on the continuous physical presence of a mature male.
Wait, really?
Yes.
Mm-hmm.
If a female cystosome manages to infect a human host but never encounters a male worm in the bloodstream, she just remains stunted.
She just never grows up.
She stays sexually immature indefinitely. She requires constant physical contact and highly specific chemical and tactile signaling from the male's gynecophoric canal to undergo the final stages of maturation and actually begin producing eggs.
Wow. So they find each other in the massive labyrinthine network of our veins. She docks into his canal, and they just stay like that.
They do?
And according to the clinical data, they stay like that for an astonishingly long time. These adult bonded pairs have a mean lifespan of 5 to 10 years inside the human vascular system.
A decade. A decade of continuous cohabitation inside the veins of your bladder or your intestines.
It's just hanging out.
And during that entire time, their primary biological function is ceaseless reproduction. Depending on the specific species, a single mated female releases anywhere between 300 to 3,000 eggs every single day.
Without pause.
Without pause, for those 5 to 10 years.
If you just do the baseline math on that, it is horrifying. 10 years, thousands of eggs a day. We are talking about millions upon millions of microscopic eggs originating from just a single pair of worms.
It's a massive biological burden.
And a heavily infected patient might have hundreds of these pairs inside them.
Easily.
Which forces us to ask the most critical question: how does this entire nightmare sequence begin? Like, how do these organisms get from a freshwater snail into the deep venous system of a human?
The life cycle.
Right. The life cycle operates in 4 very distinct stages, and it's basically a masterpiece of pathogenic engineering. Let's break it down.
The journey is complex, and it's actually highly perilous for the parasite. Let's trace it sequentially, starting from the dispersal phase. Stage 1, the egg and the myristidium. The entire life cycle officially initiates when the eggs are passed out of the infected human's body. Depending on which species of adult worms are present, and therefore which organs they reside in, the eggs are expelled either in the human's urine or in their excrement.
So the human is essentially seeding the environment.
Unfortunately, yes. But those eggs are completely inert until they hit the right conditions. They need to find their way into fresh water.
Fresh water is the trigger.
The absolute trigger.
Ah.
Upon contacting the different osmotic pressure of fresh water, the eggs immediately hatch.
And out comes the little worm.
Actually, no. What emerges is not a miniature worm. It is a highly motile, ciliated larval form known as a miracidium.
A miracidium.
Yes, ciliated, meaning it is completely covered in microscopic hairs that allow it to actively swim through the water.
Okay, so stage 1 is complete. The egg has hatched. We have the miracidium. What is this microscopic swimmer trying to accomplish?
It has a singular, really time-sensitive directive. It must locate an intermediate host, the snail. And it cannot be just any random snail. It must be a very specific species of water-dwelling snail that is biologically compatible with that exact species of schistosome.
How does it find it? Does it have eyes?
No, it follows chemical trails in the water. It's essentially smelling the snail.
Oh, wow.
Once it makes contact, it uses specialized enzymes to dissolve the snail's tissue, penetrate the flesh, and get inside.
Just burrows right in.
Right.
Yeah.
And once secure inside the snail, it drops its swimming cilia and begins that digenetic asexual phase we discussed earlier. It transforms into a structure called a sporocyst.
So this single miracidium invades the snail and essentially hijacks the snail's biology, turning it into a parasite cloning factory.
Exactly.
The sporocyst begins rapidly dividing. The clinical timeline says this incubation inside the snail takes about 4 to 6 weeks. So what exactly emerges from the snail after that month-long cloning process?
Over those 4 to 6 weeks, the rapidly dividing sporocysts develop into the next distinct larval stage, called cercaria.
Cercaria.
And the sheer volume is staggering.
Yeah.
Thousands of these cercariae are shed from a single infected snail every single day. They re-enter the freshwater environment, and they are completely invisible to the naked eye.
This brings us to stage 2, which is the actual transmission mechanism. And this is arguably the most terrifying aspect of the whole disease.
It really is.
Because when we think of tropical parasites, we usually think of ingestion, right? Like drinking contaminated water or eating undercooked meat.
Right, like a tapeworm.
Exactly.
Yeah.
But humans absolutely do not have to swallow these cercariae to get infected. The cercariae swim through the water, seek out human skin, and penetrate it directly on contact.
Yeah.
You literally just have to be wading, bathing, or doing laundry in the water.
Is an active, aggressive invasion. The cercariae are equipped with a forked tail for rapid swimming and a really specialized head containing penetration glands.
So they are built to breach.
Oh, absolutely.
Yeah.
When they sense the specific lipids and thermal signature of human skin,
They sense our body heat.
body heat and skin oils, they attach. Then they secrete powerful enzymatic cocktails that literally break down the intracellular bonds of the intact epidermal layer.
That is horrifying.
Through a combination of chemical melting and vigorous mechanical wriggling, they breach the skin barrier and enter the underlying tissues in a matter of minutes.
Wow.
It is also important to highlight a vital epidemiological nuance here regarding the host reservoir.
Okay, what's that?
While humans are the primary definitive hosts for all 6 species, Schistosoma japonicum and potentially Schistosoma mekongii have the ability to infect other vertebrate mammals as well.
Meaning they don't strictly need a human to keep their life cycle going.
Exactly. This creates what is known as an animal reservoir of infection.
Like what kind of animals?
Water buffaloes, domesticated dogs, pigs, cattle. They can all wade into the water, become infected, and subsequently shed eggs back into the environment.
I imagine that makes controlling the disease incredibly difficult.
Monumentally more difficult. Eradicating those specific Asian species is a public health nightmare because treating the human population doesn't eliminate the environmental threat. The animals keep the cycle going.
Okay, that significantly complicates things. But let's follow the parasite that did find a human. Stage 3. The breach has occurred. The cercariae have dissolved their way through the skin layer. What happens the second they are inside the human body?
The moment they successfully breach the skin, a profound physical transformation occurs. They rapidly shed their forked swimming tails. They have no further use for them inside the host, and they alter their outer surface membrane to begin evading the human immune system.
They drop the tail and put on the camouflage.
Exactly. At this exact moment, they are officially reclassified. So they are no longer cercaria. They're now referred to as Schistosomia.
Schistosomia. Okay, let's track the timeline so far. We have
Yeah.
the egg, which hatches into the miracidium in the water. The Myristidium invades the snail and becomes Cercaria. The Cercaria penetrates the human skin and becomes Schistosomula.
Perfect, yes. The schistosomula are essentially microscopic juvenile worms, and their immediate biological imperative is migration.
Where are they trying to go?
Well, first they burrow through the local subcutaneous tissues until they hit either the lymphatic system or the peripheral blood vessels.
They just dig until they hit a vein.
Right. And once they breach a vessel, they just let the flow of the human circulatory system do all the work. They take a circulatory ride through the right side of the heart and are pumped directly into the lungs.
So they make a pit stop in the pulmonary system. Do they stay there?
Only briefly. They have to physically navigate the tiny capillaries of the lungs to cross over into the systemic circulation.
That sounds like a tight squeeze.
It is, which
Yeah.
causes some symptoms we'll talk about later. But from the lungs, they are pumped out to the rest of the body. Their specific target destination, though, is the liver.
The liver.
The liver acts as the great incubator for the parasite. The schistosomula lodge in the really rich blood vessels of the liver and reside there for approximately 6 weeks.
Just feeding.
Gorging on nutrients from the host's blood, growing rapidly, and finally maturing into the fully developed adult male and female worms.
And it's in the liver where they finally find each other, right? They pair up into that permanent biological docking station we talked about and prepare to establish their long-term residence.
Exactly.
Which takes us to stage 4, the final destination.
Because they don't stay in the liver forever.
Yeah.
Where do these mature mated pairs actually travel to live for the next decade?
This final migration depends entirely on the specific genetic programming of the species involved.
Okay.
Once mature, the bonded pairs actually swim against the flow of venous blood.
Read, they swim upstream.
They swim upstream, navigating down from the liver to reach their final anatomical homes in highly specific venous circulations. The internal map is very clearly defined.
Give me an example.
If a patient is infected with Schistosoma hematobium, those adult worms purposefully migrate to the venous plexuses, which is the intricate network of veins that surround the bladder, the prostate, and the uterus. So hematobium strictly targets the genitourinary system. It goes low.
Exactly.
What about the other 5 species?
The other 5, Mansoni, Japonicum, Intercalatum, McCongie, and Malaensis, they're all drawn to the gastrointestinal tract.
Okay, the gut.
Yeah, they migrate against the portal blood flow to take up residence in the portal vein, the inferior mesenteric vein, and the superior mesenteric vein.
Those are major blood vessels.
Massive ones. They are responsible for draining deoxygenated, nutrient-rich blood from the intestines and the rectum straight back toward the liver.
Man, let's pause and synthesize what we've learned so far because the sheer mechanics of this are staggering. You have adult worms living directly inside the veins of your bladder or your intestines, surviving for up to 10 years.
Right.
Now, a natural assumption would be that the physical presence of the worms is what destroys the organs. Like you'd think they're biting the tissue or physically blocking the blood vessels or consuming the organ itself.
That's what most people think.
But this is where the true insidious nature of the disease reveals itself. The massive systemic, devastating physical damage isn't caused by the worms at all. It is entirely caused by the eggs.
That is the central defining pathophysiological concept of schistosomiasis. It is fundamentally an egg-driven disease.
Egg-driven.
The adult worms themselves are remarkably adept at existing peacefully within the host. Like we said, they disguise their outer tegument or skin with host proteins. They effectively render themselves invisible to the immune system.
They're just coasting.
But remember the reproductive math. Those females are laying hundreds or thousands of eggs every single day.
Right, thousands.
The biological goal of the parasite is for those newly laid eggs to cross out of the blood vessel, pass physically through the dense tissue wall of the bladder or the intestine, and successfully exit the human body in urine or feces.
To reach fresh water and continue the life cycle.
Exactly.
But getting a microscopic egg to push through solid organ tissue, I mean, that sounds biologically impossible.
That's not easy.
The notes detail a truly violent microscopic mechanism for how they accomplish this. The larval form that is rapidly developing inside the egg, that Myristidium we talked about, it doesn't just sit there waiting.
No, it's very active.
It actively secretes highly caustic proteolytic enzymes. It literally produces chemical acids that seep out through microscopic pores in the eggshell,
Yeah.
and it actively melts and dissolves the human tissue surrounding it, slowly digesting a path from the blood vessel through the solid muscle wall and into the open lumen of the gut or the bladder.
It is a brutal,
Mm.
chemically driven exit strategy.
Mm.
The egg is essentially burning its way out of the host.
That is incredible and horrifying.
But here is the critical systemic problem. This method is highly inefficient. The clinical data highlights a devastating reality. Up to 50% of the eggs laid never successfully navigate out of the body.
50%, so half of them get stuck.
They embolize.
Embolization. Okay, in medical terms, this means they get swept away by the current of the bloodstream and lodged somewhere they aren't supposed to be, right?
Exactly. The eggs are laid in flowing blood vessels. Half of them fail to grip the vessel wall and are simply swept away by the venous return.
So where do they go?
They flow back into the liver, into the lungs, sometimes all the way up to the brain, or they simply get trapped deep within the dense fibrous tissue walls of the bladder and intestines, just unable to dissolve their way completely out.
I just get stuck in the meat of the organ.
Right. And while the stealthy adult worms are being ignored by the body, the human immune system violently, aggressively recognizes these thousands of trapped enzyme-leaking eggs as highly dangerous foreign invaders.
Because they're leaking acid, the body has no choice but to launch a massive counterattack.
Exactly.
The medical text described this specific immune response as a highly regulated, delayed hypersensitivity reaction. Let's translate that into understandable mechanics. What exactly does a delayed hypersensitivity reaction look like at the cellular level? Who is coordinating this microscopic war against these trapped eggs?
The coordination of this war happens at the absolute highest echelons of the immune system. The induction and subsequent modulation of this massive immune response is entirely under the control of specific clones of white blood cells known as CD4 and CD8 T cells.
CD4 and CD8?
You can think of CD4 and CD8 cells as the generals and tactical commanders of the immune system. They are constantly patrolling the body.
Looking for trouble.
Right. When they detect the highly inflammatory proteolytic enzymes and the specific parasite antigens leaking from these trapped eggs, they immediately sound the systemic alarm.
And how do they communicate that alarm across the whole body to summon reinforcements? Do they send out a signal?
They use a complex language of chemical messengers called cytokines.
Cytokines.
Yeah, you could think of cytokines as essentially biochemical flare guns. The research specifically identifies two incredibly important cytokines in this disease process.
Okay, what's the first one?
The first is interleukin-7, or IL-7. This one heavily drives and influences the localized immune response in the skin during that initial penetration of the cercaria.
So IL-7 handles the skin breach.
Right. The second one is interferon gamma, or IFN gamma. This cytokine is the primary driver of the massive inflammatory cascade in the liver and other deep organs where the eggs get trapped.
Okay, so what happens when they fire that interferon gamma flare?
When the T cells release interferon gamma, it recruits tens of thousands of inflammatory cells, macrophages, eosinophils, lymphocytes, basically commanding them to swarm and surround the trapped egg.
And that dense, swarming, spherical cluster of angry immune cells physically wrapping around the egg that forms a biological structure called a granuloma.
Precisely. A granuloma is the body's desperate attempt to wall off and quarantine a foreign invader that it cannot easily kill or digest.
Because the eggshell is too tough.
Because the eggshell is incredibly tough, so the immune cells simply build a thick inflammatory prison around it.
How fast does that happen?
The timeline is remarkably fast. These granulomas begin forming around the maturing mycelium inside the trapped egg within just 6 days of the egg being laid.
Wow, 6 days.
And they organize into dense, focal, fibrotic structures within 2 weeks.
Okay, we have to scale this up to really understand the pathology here. You have thousands of eggs getting trapped in the body every single day for years.
Thousands a day.
And around every single one of those microscopic eggs, your body builds an intense, inflamed, spherical granuloma. Over months and years, these granulomas calcify and turn into rigid scar tissue.
Which completely destroys the architecture of the organ.
Exactly. So where are the most common battlegrounds for this microscopic war?
The location of the collateral damage maps perfectly to the specific venous homes of the different species.
Makes sense.
So for Schistosoma, intercalatum, japonicum, and mansoni, the species living in the mesenteric veins, draining the intestines, the embolized eggs are naturally swept via the portal vein directly into the liver.
So the liver catches them all.
The liver acts as a massive filter, trapping millions of eggs over time. So it becomes the primary site of rampant granuloma formation, leading to severe progressive liver disease.
What about hematobium?
Conversely, for Schistosoma hematobium, the adult worms are down in the venous plexuses of the bladder. So the eggs get trapped deep in the muscular walls of the bladder, the ureters, and the reproductive organs.
Which causes devastating structural genitourinary complications.
Exactly.
Okay, we have established the microscopic pathology, the invisible, decade-long war happening inside the veins, the liver, and the bladder. Now, how does this actually manifest in a human being? Let's move our focus from the microscope to the patient's bedside.
The clinical presentation.
Right. The clinical text outlines three major distinct clinical syndromes that manifest as the disease progresses through different stages. Let's start with the very first word, Syndrome 1, which the text refers to as cercarial dermatitis.
Clinically, it's cercarial dermatitis, but it is almost universally known colloquially as swimmer's itch.
Swimmer's itch. That sounds unpleasant.
It is the very first clinical sign of infection, occurring almost immediately within hours or days after exposure to infested water.
So right after the worms breach the skin.
Exactly. However, there is an interesting epidemiological caveat here. It does not happen to everyone.
Really?
The data shows it only occurs in about 5 to 10% of infected individuals.
Oh, wow. That's really low. Why is that?
It is typically seen in patients who suffer extremely heavy initial infestations, like they got hit by hundreds of cercaria at once, or in individuals who have had repeated prior exposures.
Meaning their immune system is already primed to react aggressively to the skin breach.
Right, they already have those antibodies ready to attack.
So someone might take a swim, get infected by a bunch of cercaria, and never even develop a rash. They'd have no idea.
Exactly, they wouldn't know until months or years later.
But for the 10% who do react, what are the actual physical symptoms of swimmer's itch?
The symptoms are a direct, localized result of the immune system detecting the cercaria as they dissolve their way through the skin. Patients experience significant localized edema, which is swelling at the penetration sites.
Like bug bites.
Similar. This is accompanied by severe pruritus, meaning intense, unrelenting itching, and urticaria, which presents as raised, red hives.
Sounds miserable.
And because it's an active immune response, the rash can also be accompanied by a feeling of general malaise and mild fatigue.
It essentially presents like a terrible, incredibly itchy allergic reaction right after swimming. But whether you get the rash or not, the parasite is already moving inward.
It's already in the blood.
So let's fast forward the timeline. The schistosomula have successfully navigated to the lungs, dropped down to the liver, matured over 6 weeks, paired up, and migrated to their final venous homes.
The life cycle is complete.
And suddenly, the females begin laying their very first massive, overwhelming wave of eggs. This systemic shock triggers Syndrome 2, acute schistosomiasis. The clinical literature also refers to this historically as Katayama fever.
Katayama fever.
The symptom list for this phase sounds absolutely harrowing.
It is profoundly miserable for the patient, and it represents a really critical juncture in the disease. It typically occurs in heavy primary infections, usually kicking in anywhere from 3 to 8 weeks after the initial water exposure.
So about a month or two later?
Right, and it perfectly coincides with the exact moment the adult worms begin mass-producing eggs. Biologically, Katayama fever is a massive, systemic, full-body hypersensitivity reaction.
Like serum sickness.
Very similar to serum sickness. It's triggered by the sudden, overwhelming flood of highly reactive egg antigens and those proteolytic enzymes entering the host's bloodstream all at once.
The clinical presentation reads like a complete multi-system crash. Patients present with sudden, high-spiking fevers, profound nausea, recurrent vomiting, and generalized lymphadenopathy.
Which means the lymph nodes all over their entire body become noticeably swollen and tender as the immune system just goes into absolute overdrive.
Then, they also suffer from severe abdominal pain and profuse diarrhea or even dysentery as the intestinal wall becomes acutely inflamed by that first wave of eggs.
It's a massive shock to the gut. But it's also important to remember the parasite's anatomical migration path when evaluating these symptoms.
You mean how they went through the lungs?
Exactly. Because the juvenile schistosomula had to physically pass through the delicate capillary beds of the lungs earlier in the life cycle, respiratory signs are also highly prevalent during this acute phase.
Oh, I see.
The clinical diagnostic criteria highlight a persistent dry cough as a very common symptom. Interestingly, this pulmonary symptom can actually manifest 3 to 6 weeks after exposure, sometimes preceding the gastrointestinal symptoms.
And occasionally occurring even without a prominent fever, right?
Yes, which can make it tricky to diagnose.
And the presentation alters slightly if the patient is infected with Schistosoma hematobium, correct? Because those worms didn't go to the intestines, they went to the bladder.
Correct. The acute inflammatory response is localized to where the eggs are actually being laid. So for acute hematobium infections, the massive sudden inflammation occurs in and around the tissue of the bladder.
So what does that look like?
This triggers intense urinary frequency, just the constant urgent need to urinate due to severe bladder irritation. But the true hallmark symptom is terminal hematuria.
Terminal hematuria. Let's define that clearly for everyone. It means the patient observes distinct, bright red blood right at the very end of the urination process.
Yes, and the mechanics of it are quite specific. The bladder wall is heavily inflamed and laden with microscopic tissue-damaging eggs.
Right.
So as the bladder muscle fully contracts at the very end of the voiding process to push the last bit of urine out, it physically squeezes that inflamed, friable tissue.
Ouch.
This mechanical squeezing causes localized bleeding, hence the blood appearing specifically at the terminal end of urination. Patients frequently also experience referred suprapubic pain.
Which is pain in the lower abdomen just above the pubic bone.
Right, or even deep perineal pain due to the severe pelvic inflammation.
Okay, so Katayama fever is the acute violent immune reaction. It's the body panicking.
The fire alarm is going off.
But eventually, that acute storm subsides. The immune system establishes a grim equilibrium with the parasite. But if the patient goes undiagnosed and untreated, which tragically happens all the time in rural endemic areas with limited access to diagnostics, the patient enters the grueling, decades-long nightmare of the disease.
The chronic phase.
This brings us to Syndrome 3, chronic fibroobstructive disease.
This is the phase where the cumulative long-term presence of millions of granulomas exerts its devastating toll on the human anatomy.
Fibroobstructive.
The term fibroobstructive perfectly and tragically describes the pathology. Over years, those cellular granulomas surrounding the trapped eggs die off and calcify. They turn into rigid, inelastic, fibrous scar tissue.
So the organs just fill with scar tissue.
This massive accumulation of scar tissue structurally obstructs the normal physiological function of the major organs.
The symptoms of this chronic phase are just unrelenting. The clinical data describes chronic, severe abdominal pain. But it's vital to understand why the abdomen hurts. It isn't just a stomach ache.
No, it's mechanical pain.
It is secondary to massive, physically palpable liver and spleen enlargement, a condition physicians refer to as hepatosplenomegaly.
Hepatosplenomegaly, yes.
There's a specific, incredibly heartbreaking detail mentioned in the epidemiological notes. The prevalence of young boys, often around 10 to 14 years old, presenting with massive, severe abdominal distension.
It's a very common presentation.
Their bellies are hugely swollen, taut as a drum, not from fat, but strictly from the sheer pathological physical size of their massively inflamed, severely scarred livers and spleens pushing outward against the abdominal wall.
It's one of the most tragic and recognizable hallmarks of chronic, untreated pediatric schistosomiasis in highly endemic regions. And the pathology driving that distension is complex.
How does the liver get that big?
As the liver becomes progressively replaced by dense scar tissue, a specific condition known as periportal fibrosis, the internal vascular architecture of the liver is literally crushed. The liver is supposed to act like a sponge, filtering blood coming from the intestines. But when it turns into a rigid block of scar tissue, blood can no longer flow through it easily.
It creates a bottleneck.
A massive physical bottleneck. The blood pressure rapidly and dangerously builds up in the veins of the entire digestive system that are trying to push blood into the liver.
So all the plumbing backs up.
This high-pressure state is called portal hypertension.
Understanding that plumbing backup explains the truly frightening gastrointestinal symptoms listed for chronic S. japonicum and S. mansoni infections.
The bleeding.
Yeah. The clinical notes list hematemesis, which is vomiting frank blood, or melena, which is passing black, tarry stools composed of digested blood.
Right.
When the liver becomes a dam, the high pressure forces the blood to find alternative, smaller pathways. The delicate veins in the esophagus and the stomach expand massively to handle the rerouted blood flow.
They become varices.
They balloon out until the internal pressure is simply too great, and the vein literally ruptures, causing catastrophic, often fatal internal bleeding.
That is exactly the mechanism. It is a catastrophic mechanical failure of the vascular system, driven entirely by years of microscopic egg-induced scarring.
If this chronic fibroobstructive phase is left unchecked, the systemic failures cascade beyond just the liver and the gastrointestinal tract. The medical review outlines some profound end-stage worst-case scenarios.
Complications are dire.
Let's break down the cardiac complications, specifically a condition listed as cor pulmonale. How does a liver or intestinal parasite destroy the heart?
Cor pulmonale is essentially the medical term for severe right-sided heart failure. And in this context, it happens secondary to severe pulmonary hypertension.
Okay, pulmonary hypertension, why does that happen?
Recall our earlier discussion about embolization, how up to 50% of the eggs are swept away by the bloodstream. Millions of these eggs bypass the liver and are carried straight into the microscopic capillary beds of the lungs.
Where they get permanently wedged.
Exactly. Over a decade, millions of granulomas form in the tiny pulmonary arteries, turning the soft, spongy tissue of the lungs into stiff scar tissue.
Like the liver.
Like the liver. This drastically increases the physical resistance to blood flow within the lungs. The right ventricle of the heart, whose sole job is to pump blood into the lungs for oxygenation, suddenly has to pump against immense, unyielding pressure.
It's like trying to force water through a concrete filter rather than a sponge.
That's a perfect analogy. The heart muscle compensates initially by thickening, getting stronger, but eventually the sheer workload is too much. The right side of the heart becomes massively enlarged and simply gives out. It fails.
And what are the symptoms of that?
This leads to profound systemic fluid retention, severe shortness of breath, and in the late stages of pulmonary schistosomiasis, hemoptysis.
Which is violently coughing up blood.
Right, as the high-pressure pulmonary vessels begin to rupture under the strain. This occurs alongside the progressing end-stage liver disease, creating a scenario of broad multi-system and organ damage.
All caused by the relentless, never-ending immune stimulus of thousands of eggs being laid every single day. Now, amid all this organ failure, I spotted a truly bizarre, highly specific secondary complication in the clinical notes that I need you to explain.
What's that?
The pathology text lists the persistence of bacteremia with Salmonella typhi and other Salmonella species.
Ah, yes, the Salmonella symbiosis.
Salmonella is a bacteria usually associated with food poisoning. Why on earth would a parasitic blood fluke infection cause chronic, persistent bacterial infections?
This is one of the most fascinating and devious examples of interspecies microbial interaction in human medicine.
Really?
Yes, Salmonella bacteria actually have a highly specific biochemical affinity for the physical surface of the adult cystosome worms.
Wait, they like the worms.
They actively seek out the worms inside the bloodstream and chemically bind themselves to the tegumen, the outer skin layer of the adult parasites living in the mesenteric or vesical veins.
You're kidding.
Because the adult worms are incredibly adept at evading the host's immune system, the attached Salmonella bacteria essentially get a free ride. They utilize the worm as an immunological safe haven.
A safe haven from the immune system and from drugs.
Yes. This incredibly strange symbiosis leads to chronic, recurrent Salmonella bacteremia in the patient that is notoriously incredibly difficult to clear with standard antibiotics.
Because the bacteria just keep hiding on the worms.
Exactly. The only way to cure the Salmonella infection is to use antiparasitic drugs to kill the underlying worms first.
They are literally using a decade-old parasitic worm as a stealth transport vehicle to hide from antibiotics. That is biological warfare on a level that is hard to comprehend.
It's incredibly clever biology.
Moving down the list of organ failures, the text extensively mentions severe renal failures.
Specifically, the literature highlights two complex conditions: dysangioproliferative glomerulonephritis and nephrosis.
Okay, those are big words. How does it destroy the kidneys?
It's crucial to understand that this kidney destruction isn't usually caused by the parasite eggs physically getting trapped in the kidney tissue. Instead, it's a collateral consequence of the immune system's overactivity.
Friendly fire.
Basically, imagine your kidney is a microscopic, highly precise colander. Its job is to let liquid waste filter through into the urine while keeping the essential proteins and blood cells inside the body.
Right.
However, because the immune system is constantly fighting millions of parasite eggs for a decade, it is mass-producing astronomical amounts of antibodies. These antibodies lock onto tiny pieces of dissolved egg proteins floating in the blood, forming sticky microscopic clumps known as immune complexes.
So you have millions of these sticky clumps of antibodies and parasite debris just floating around in the bloodstream.
Yes, and as the blood is pumped through the kidneys for filtration, these heavy, sticky immune complexes hit that delicate microscopic colander, the glomerulus, and they get wedged in the filter pores.
Oh, they clogged the filter.
They accumulate in massive numbers. The colander gets physically blocked, becomes intensely inflamed, swells up, and completely loses its ability to filter correctly.
So what happens to the patient?
Massive amounts of vital proteins begin leaking out into the urine, which is nephrosis, and the kidneys progressively fail due to the intense inflammation, resulting in glomerulonephritis.
Unbelievable. The complications just continue cascading into severe reproductive and developmental issues. The pediatric notes list significantly retarded puberty and stunted growth,
Which makes grim sense given the massive daily nutritional drain the parasites demand.
coupled with the profound calorie-burning effects of chronic systemic inflammation. But the text also lists horrifying structural reproductive issues for women, a high incidence of ectopic and tubal pregnancies and tubal abortion.
This is a particularly devastating consequence, primarily associated with schistosoma hematobium infections, a condition now broadly recognized as female genital schistosomiasis, or FGS.
FGS.
Because the adult worms reside in the venous plexuses of the entire pelvic region, the eggs don't just get trapped in the bladder. They frequently embolize and get deeply trapped in the mucosal tissues of the fallopian tubes, the uterus, the cervix, and the vagina.
Oh my God.
The resulting immune response creates dense granulomas and thick fibrous scarring that physically distorts the reproductive anatomy. If the delicate internal lumen of the fallopian tube is scarred and blocked, a fertilized egg cannot successfully travel down to the uterus.
It gets stuck in the tube.
It gets stuck, resulting in a life-threatening ectopic pregnancy. Furthermore, the constant open ulcerative lesions caused by the eggs physically dissolving their way through the genital mucosa create a massively increased vulnerability to contracting other sexually transmitted diseases.
Like HIV.
Exactly. It's a significant risk factor for the transmission of HIV in endemic areas.
And wrapping up the systemic complications, almost every patient suffers from general severe anemia. This is driven by chronic daily blood loss, either from the persistent terminal hematuria in the bladder or the slow, unseen intestinal bleeding.
Which leaves the patient in a state of constant, profound physical exhaustion.
So, as a medical professional, if you are confronted with a patient presenting this massive, incredibly diverse array of symptoms, recurrent fevers, coughing up blood, a massively enlarged spleen, an itchy rash, painful urination, and chronic anemia, how does a doctor actually pin down schistosomiasis among a sea of tropical diseases?
It's not easy.
That brings us to the crucial detective work of diagnosis.
Right. Reaching a definitive diagnosis requires a very high index of clinical suspicion, precisely because the disease mimics so many other conditions. A patient presenting with such a wide array of systemic symptoms forces the physician to navigate a massive list of differential diagnoses.
They have to rule a lot of things out.
They must systematically rule out several very common red herrings.
The notes list several of these differentials. If a patient comes in with acute diarrhea, abdominal pain, and fever, a doctor's first thought is usually standard gastroenteritis or perhaps a primary salmonellosis infection. If they present with jaundice and a swollen, tender liver, the immediate assumption is often hepatitis A, B, or C. If the primary complaint is urinary urgency and pain, it looks exactly like a standard bacterial urinary tract infection.
It looks just like a UTI.
The clinical text even mentions that for some of the severe pediatric presentations involving organ swelling and fluid retention, doctors have to carefully rule out antenatal hydronephrosis, which is a structural kidney swelling and even congenital heart disease.
The symptom overlap is just immense. Because of this, before ordering expensive scans or invasive biopsies, the single most paramount, indispensable tool the physician has is taking a meticulous patient history.
The history is everything.
The doctor must establish one singular, critical fact. Has the patient had any recent or even distant freshwater contact in a known endemic area?
Like, did you swim in Lake Malawi?
Have they swam in a lake, waded in an irrigation canal, or washed clothes in a river in Africa, South America, Asia, or the Middle East? If the answer is no, schistosomiasis is virtually impossible.
But if the answer is yes...
If the answer is yes, it immediately moves to the absolute top of the differential list.
That single question regarding water exposure cracks the entire case open.
It really does. Once that epidemiological history is firmly established, the physical examination must be highly targeted.
What are they looking for?
The clinician is looking for the classic hallmarks of the chronic fibroobstructive disease phase. The most prominent findings will be severe abdominal distension and palpable organomegaly.
Feeling the organs.
The doctor will physically press on the abdomen to feel the margins of the liver and the spleen, assessing for the hardened, massively enlarged organs that define hepatosplenomegaly.
Okay, so the history fits, the physical exam points to it, but we suspect schistosomiasis. We don't know it yet. We need definitive, undeniable proof.
The gold standard.
Right. In parasitology, the gold standard for definitive diagnosis is physically finding the actual parasite eggs excreted in the patient's stool or their urine under a microscope. But as I was reading the clinical procedures in the notes, I found what is absolutely my favorite detail in this entire massive medical document. It provides a highly specific, seemingly bizarre instruction for the laboratory collection of urine to find S. hematobium eggs.
The timing.
Yes, it explicitly states collection of urine is usually recommended between noon and 2:00 p.m. I had to read that 3 times. Why is a medical textbook giving a 2-hour window? Do the parasite eggs operate on a strict lunch schedule? What is the biological mechanism happening here?
It sounds completely absurd to mandate a specific hour for a urine sample, but it is a perfectly documented, highly reliable clinical phenomenon.
Tell me how this works.
Remarkably, the excretion of Schistosoma hematobium ova through the bladder wall into the urine does not happen at a steady, continuous rate throughout the day. It operates on a distinct diurnal rhythm, a daily fluctuating cycle.
Okay.
The clinical data shows that the excretion of eggs is at its absolute peak, its greatest concentration and volume, precisely between midday and early afternoon, roughly 12:00 p.m. to 2:00 p.m.
But why? How do microscopic worms living deep inside a dark pelvic vein know what time of day it is?
It is a breathtaking example of evolutionary adaptation. The parasites are intrinsically tied to the host's hormonal circadian rhythms, specifically core body temperature and activity levels.
Wait, they monitor our temperature.
They do. Midday to early afternoon is historically the exact time when human hosts in hot, tropical endemic areas are most likely to be active near or directly in freshwater sources.
Oh, no.
That is when people go to the river to bathe, to cool off from the midday sun, or to wash the day's clothes. By utilizing the host's own circadian biology to trigger the maximum concentrated release of eggs at the exact time the host is most likely to be standing in water, the parasite exponentially maximizes the chances of those eggs reaching a freshwater source to hatch into Miracidia and find a snail.
That is just terrifying elegance. They're literally synced to our circadian rhythms to optimize their own reproductive success.
It's brilliant biology.
So the clinic makes sure to collect the urine right after noon. Now, the text notes that this peak excretion phase typically happens 5 to 13 weeks after the initial infection, and the volume of eggs is determined by the total worm burden in the patient.
Right.
But what if the infection is chronic, the scarring is so thick the eggs can't get out, and the urine and stool samples come back negative? What other diagnostic tools do doctors deploy?
When direct microscopy fails, we pivot to a multi-pronged diagnostic approach. We will run a full blood count, an FBC.
What does that show?
In a patient with schistosomiasis, the FBC will almost invariably show profound eosinophilia, that massive spike in the specific white blood cells we discussed earlier that are heavily linked to fighting parasitic infections.
Okay, the heavy artillery is deployed.
We also utilize advanced serology tests. These blood tests look for these specific, targeted antibodies that the patient's immune system has formed against the parasite antigens. If the antibodies are present, it confirms exposure.
But what if you need to see the actual damage?
In severe chronic cases where the eggs are deeply trapped in fibrotic tissue and not shedding, a direct tissue biopsy may be required. This involves taking a microscopic pinch of tissue from the bladder wall or the rectal mucosa to physically visualize the granulomas under a microscope.
And what about seeing the internal structural damage? You mentioned the organomegaly and the rigid livers. How do doctors assess the physical state of the internal plumbing?
That assessment relies heavily on radiological tools. Ultrasound scans are the frontline imaging modality. They're excellent, cheap, non-invasive, and highly portable, making them ideal for rural clinics.
So you can see the liver size.
Ultrasounds can clearly visualize the extent of liver scarring, measure the exact size of the spleen, and assess the blood flow in the portal vein.
What about x-rays?
X-rays are also vital, particularly for hematobium infections. Chronic inflammation can cause the entire bladder wall to become so heavily embedded with calcified dead eggs that it actually appears as a hard, opaque white shell on a standard pelvic X-ray.
A calcified bladder, that's awful.
It is. And for the most severe, complex cases, CT scans and MRI imaging are crucial for assessing precise end organ damage, particularly if there is suspicion that eggs have embolized into the delicate tissues of the brain or the spinal cord.
Okay. The exhaustive detective work is done. The epidemiological history of swimming in Lake Malawi fits perfectly. The physical exam showed an enlarged liver. The 12-2 PM to 2.00 PM urine sample came back positive for the characteristic eggs.
The diagnosis is absolutely confirmed.
And this brings us to the pharmacological arsenal. How does modern medicine actually kill these mated pairs of worms that have been living comfortably in the patient's veins, evading the immune system for potentially a decade?
The incredibly good news in this otherwise grim medical picture is that we possess a highly effective, targeted pharmacological weapon.
Thank goodness.
The undisputed drug of choice, the absolute frontline gold standard treatment utilized globally, is an anthelmintic medication called praziquantel.
Praziquantel. What is the actual mechanism of action? How does a pill swallowed into the stomach kill a worm hiding in the pelvic veins?
Praziquantel operates by disrupting the fundamental cellular biology of the parasite. While the exact biochemical pathways are complex, the primary mechanism is that praziquantel causes a rapid, massive influx of calcium ions into the worm's muscle cells.
Calcium.
Right. Calcium is the trigger for muscle contraction. This sudden flood of calcium triggers severe, sustained, tetanic muscle spasms and complete, rigid paralysis in the worm.
It just locks up.
Because it is paralyzed, it can no longer grip the walls of the blood vessel and is swept away. Furthermore, praziquantel physically damages and strips away the worm's outer skin, the tegument.
So it drops its camouflage.
Exactly. This suddenly and violently exposes all those hidden parasite antigens to the human immune system. The host's white blood cells, which have been ignoring the worm for years, suddenly recognize it as foreign and sweep in to rapidly destroy the paralyzed parasite.
It's a brilliant two-step attack. Paralyze them, strip their camouflage, and let the host's own immune system finish the job.
It works beautifully.
Now, the clinical notes detail very exact dosing regimens, and it stresses that the treatment protocol is not one size fits all. It depends entirely on the specific species of schistosome identified in the lab. Some of these worms are biochemically tougher than others.
That is a critical clinical distinction. Let's look at the specific dosing guidelines. For infections caused by Schistosoma hematobium, Schistosoma intercalatum, and Schistosoma mansoni, the parasite is relatively susceptible.
Okay, so what's the dose?
The standard dosage protocol is 20 milligrams of praziquantel per kilogram of the patient's body weight, taken orally noted as PO twice daily, strictly for a single day.
Wait, really?
So 20 milligkg PO twice on day 1 and the treatment course is complete.
That seems remarkably brief. 2 doses in one day to cure a decade-long infection. That's amazing. But what about the other species?
The Asian species, specifically Schistosoma japonicum and Schistosoma macangi, are notoriously more robust and far more resistant to the drug's effects.
Do they need more?
For these species, the dosage requires an extra pharmacological hit. The base dose is still 20 milligrams per kilogram, but it must be taken 3 times a day, clinically noted as ATDS on day 1.
Okay, so 20 kilograms TDS on day 1 for the tougher ones. That handles the adult worms beautifully. But the notes highlight a critical blind spot in this treatment.
Right, the early stages.
What if we catch the infection incredibly early? Say a patient knows they just fell into infested water a week ago and we want to stop the migrating schistosomia from ever growing up. Can we just give them praziquantel?
No. And that is a vital point regarding early intervention and prophylaxis. Praziquantel is brilliantly, ruthlessly effective against mature adult worms, but it is generally ineffective against the migrating juvenile schistosomia.
Why is that?
Their cellular structure hasn't developed the specific targets the drug attacks yet. To kill the juveniles, the clinical text highlights a completely different medication, artemether.
Artemether. That name is famous in tropical medicine. Isn't that primarily an anti-malarial drug?
It is indeed a frontline anti-malarial derived from artemisinin. However, extensive clinical research has shown it to be highly effective against the larval schistosomia, specifically during the first 3 weeks of the infection process, while they're migrating and maturing in the liver.
Okay, so it kills the kids, not the adults.
Because of this specific efficacy, it can act as a highly effective prophylaxis in areas of intense endemicity. If a local worker knows they are constantly, daily exposed to the water, Prophylactic artemether can systematically kill the juvenile worms before they ever mature into egg-laying adults.
And the clinical trials mentioned in the notes suggest combining the two drugs. They show that a combination therapy of artemether and praziquantel offers highly beneficial synergistic effects.
It covers all the bases.
You use the artemether to hunt down and kill the migrating juveniles in the liver, and you use the praziquantel to paralyze and destroy any established adult worms in the veins. A comprehensive two-pronged pharmacological attack.
Precisely. Utilizing both drugs provides comprehensive, overlapping coverage across all the parasite's developmental stages within the human body, drastically reducing the chance of treatment failure.
That sounds like a definitive pharmacological victory. We have the tools to kill the parasite. But reading through the final sections of the medical review, there is a very sobering, grim reality that we have to confront.
The damage is already done.
Right. Praziquantel can paralyze and dissolve the worm, but no pill on earth can undo the massive physical, structural destruction caused by years of trapped eggs, dense calcification, and rigid, fibrous granulomas.
It can't dissolve scar tissue.
The parasite might be dead, but the devastating scar tissue remains permanently. And repairing that mechanical damage requires intense surgical management.
That is the tragic, enduring legacy of chronic schistosomiasis. You can achieve a complete parasitological cure, but the patient may still suffer and ultimately die from the permanent anatomical alterations left behind.
What kind of surgeries are we talking about?
The text lists several incredibly heavy invasive surgical requirements to manage these long-term end-stage conditions. Let's start with the gastrointestinal and genitourinary tracts.
Okay.
The chronic, unrelenting inflammation caused by the trapped eggs frequently leads to the chaotic growth of inflammatory polyps, masses of tissue protruding from the organ walls.
Which have to be removed.
Surgeons frequently have to perform endoscopic or open resection of bladder and colonic polyps. This is necessary to restore normal organ volume and function, but also critically to rule out malignancy.
Cancer.
Because we know that decades of chronic cellular inflammation heavily predispose the affected tissues to developing cancer down the line.
And what about the severe plumbing issues in the urinary tract caused by hematobium?
Urologists have to perform complex correction of obstructive uropathy. If the ureters, the delicate tubes connecting the kidneys down to the bladder, are heavily scarred, narrowed, and blocked by calcified granulomas, urine backs up into the kidneys, destroying them.
So they have to fix the tubes.
Surgeons must physically go in and reconstruct, stent, or entirely bypass those fibrotic blockages to save the kidneys from irreversible failure.
And in the gut.
In the GI tract, if the granulomatous scarring is extensive enough to cause bowel obstruction, general surgeons may need to perform a partial colectomy, physically cutting out and removing heavily diseased, rigid segments of the colon due to severe GI polyposis and fibrosis.
Those are massive, life-altering surgeries. But I want to revisit the liver pathology. What about the portal hypertension? We talked about the liver becoming a brick of scar tissue, blood backing up into the spleen, and the veins in the esophagus exploding.
That is an emergency.
How do surgeons fix a plumbing problem of that magnitude when the liver itself is permanently destroyed?
To prevent the patient from rapidly bleeding to death from ruptured esophageal or gastric varices, vascular surgeons may perform a highly specialized procedure called the placement of a distal splenorenal shunt.
Distal splenorenal shunt. How does that work?
To understand this, imagine a blocked highway causing a massive traffic jam. The liver is the blocked highway. The blood coming from the massively enlarged spleen is the traffic jam, building up immense lethal pressure.
Okay.
The surgeon performs a complex vascular bypass. They detach the splenic vein from its normal route toward the liver, and they physically sew it directly into the side of the left renal vein, which drains the kidney.
Oh, wow. They just reroute it completely.
This completely redirects the high-pressure blood flow away from the scarred liver and dumps it directly into the systemic circulation, immediately depressurizing the delicate veins of the digestive system and preventing catastrophic hemorrhage.
The mechanics of redirecting major organ blood flow just to survive a parasite is staggering. But there is one surgical intervention listed in these notes that absolutely stopped me in my tracks.
I know which one you're talking about.
It represents the absolute most extreme, terrifying outcome mentioned in the entire document. The text lists resection of cerebral cortical granulomas.
Brain surgery.
Brain surgery. If the pharmacological chemotherapy fails to cross the blood-brain barrier effectively, neurosurgeons literally have to open the human skull, go into the brain cortex, and physically cut out granulomas caused by eggs from a microscopic water snail parasite.
It is a rare but neurologically devastating complication. It is most usually seen with Schistosoma japonicum infection,
Mm.
primarily because the eggs of japonicum are physically smaller and more spherical than the other species,
Making it easier for them to travel.
allowing them to more easily navigate the systemic circulatory system and embolize deep within the central nervous system. When thousands of those eggs lodge in the gray matter of the brain cortex, the resulting inflammatory granulomas act exactly like rapidly growing brain tumors.
And what does that do to the patient?
They cause severe localized swelling, leading to intractable seizures, profound paralysis, and rapid neurological deficits.
So if drugs don't work,
If aggressive antiparasitic drugs and massive doses of heavy steroids cannot reduce the cerebral inflammation, an invasive craniotomy and neurosurgical resection is the absolute only option remaining to relieve the potentially fatal intracranial pressure and physically remove the parasitic mass.
a literal brain surgery complete with a craniotomy, all ultimately triggered by a simple dip in a freshwater lake a decade prior. It profoundly underscores the absolute gravity and systemic reach of this disease.
It really does.
As we pull back and look at the whole picture, let's talk about prognosis in the future. After understanding the sheer horror of the chronic complications, give us some perspective. What actually happens to a patient after they receive the correct course of praziquantel?
Despite the severity of the potential complications, there is a very real glimmer of clinical hope. The pharmacological treatments are demonstrably highly effective.
So most people get better.
The epidemiological data notes that definitive cure rates range from 65 to 90% after just a single treatment course of praziquantel.
That's incredibly high.
Furthermore, even in those individuals who were not entirely cured by the first round, perhaps because they possessed a massive initial worm burden that the drug couldn't fully clear, the sheer volume of daily egg excretion is reduced by more than 90%.
And because it's an egg-driven disease, that massive 90% reduction in egg output essentially stops the progression of the fibro-obstructive scarring dead in its tracks.
Exactly. It halts the ongoing accumulation of damage, giving the body a chance to stabilize. However, the overall long-term prognosis for any given patient depends heavily on a matrix of several factors.
Like what?
Well, the initial parasite burden, exactly how many worms they harbored, the host's baseline immunological status, any existing comorbidities like malnutrition or concurrent infections.
And timing, I imagine.
And most importantly, the timing of the therapeutic intervention. Did the clinic catch the infection in the acute phase, or are they treating it after 10 years of silent, continuous fibrotic scarring?
The earlier the intervention, the better the outcome. But what about stopping the infection from ever happening? We talked about Artemeter for high-risk workers, but broadly speaking, how does global health prevent this?
The medical consensus is blunt and uncompromising. Prevention remains strictly behavioral and environmental for the foreseeable future. The absolute mainstay of prevention is the strict avoidance of any freshwater contact in known endemic areas.
So no waiting, no swimming, no cooling off, no washing clothes or gathering drinking water in the local lake or river.
None.
Which, from a public health perspective, is incredibly, almost impossibly difficult to enforce for the millions of people living in rural poverty who rely entirely on those natural water sources for their daily agricultural and domestic survival.
It is a profound, deeply entrenched socioeconomic challenge that goes far beyond simple medical intervention. It requires massive infrastructure development for clean water access.
Are they working on a vaccine?
The clinical review does note that intense research for prophylactic vaccines is ongoing. However, developing a highly effective vaccine against a massive, complex, multicellular eukaryotic parasite, one that has evolved sophisticated, dedicated mechanisms to actively evade and manipulate the human immune system, is scientifically daunting.
It's just too smart.
It remains the ultimate, yet elusive goal for global health initiatives.
We have truly dissected every aspect of this incredible biological threat. We've covered the geography, the 6 distinct species names, the bizarre shape-shifting digenetic and dioecious biology. We've traced the incredible multi-host journey from the ciliated miracidium to the sporocyst, to the skin-penetrating cercaria, down to the mature adult worm residing in the pelvic veins.
A long journey.
We've broken down the devastating egg-driven immune response of granulomas, the brilliant evolutionary adaptation of the 12 p.m. urine tests, the precise praziquantel dosing protocols, and the extreme life-altering surgical fallout. It is a massive amount of clinical information to synthesize.
It truly is. But understanding this complete clinical picture is a testament to the staggering complexity of host-parasite interactions.
Definitely.
The sheer evolutionary ingenuity and biological mechanical engineering required for this organism to survive, navigate, and thrive inside the hostile environment of the human vascular system is, objectively speaking, an absolute marvel of nature, however devastating it may be to the host.
It is a dark marvel, without a doubt. And as we wrap up this deep dive, I want to leave you, our listener, with a final thought to ponder. Consider the unseen, silent, million-year evolutionary arms race happening right now, just beneath the calm, sunlit surface of a quiet tropical lake.
It's always happening.
We are dealing with a microscopic organism that evolved to perfectly mimic our own internal biology, hiding in plain sight within our blood vessels for a decade, coordinating its violent reproductive cycle with our daily circadian rhythms. If this microscopic fruit can manipulate the complex human immune system with such terrifying, devastating elegance, literally turning our own cellular defense mechanisms into the very weapon that destroys our internal organs, what else might we learn about the deepest, most complex secrets of our own biology by intensely studying the very things that are trying so perfectly to survive inside of us?
It's a profound question.
The next time you look at a calm body of water, remember, the surface never tells the whole story. Thanks for joining us for this analysis. Keep questioning, keep learning.